Okay, let's come on to stimulation in terms of the things that we actually do within the laboratory and what can impact on oocyte quality. What about pre-treatment with metformin? Well, the idea has been around a long time. Clearly, this was an amazing serendipitous finding that came to us from the endocrinologists who were treating their diabetic patients with metformin and then just noticed that they were all getting pregnant. So I think it's reasonably well accepted the role of metformin in terms of ovulation induction. I do think following the excellent work of Rick Legros, where he trialed Clomid against Clomid and metformin, he was able to show that metformin probably shouldn't be first-line treatment for ovulation induction. But I think there's been a lot of interest in the role of metformin before IVF. There are good theoretical reasons as to why metformin may alter stimulation protocols and give us better results. It suppresses insulin levels, it may reduce hyperinsulinemia and hyperandrogenism, which suppresses the ovarian response. And so therefore there is an underlying reason as to why it may improve both pregnancy and live birth rates. However, the evidence is not that supportive. And if we look at the Cochrane database of systematic reviews, which is probably the best way of assessing evidence, looking only at trials of sufficient statistical quality to be considered, all of the trials show, in fact, when they're put together, that there is no improvement in live birth rates or clinical pregnancy rates when we pre-treat with metformin. This is in patients with polycystic ovarian disease, or the full syndrome. However, pre-treatment with metformin is shown to produce a significant reduction in ovarian hyperstimulation syndrome, and that reduction is quite significant. However, about 10 to 15% of the patients will suffer very significant gastrointestinal symptoms, usually very bad diarrhea, and it can get so bad that it will actually force those patients to reduce or to stop their treatment. Our own team looked at the use of patients with metformin who had polycystic ovaries on ultrasound, but actually didn't have the full-blown polycystic ovarian syndrome. And in fact, we showed the same thing. It showed no improvement in embryo quality, no improvement in pregnancy rate, but did show a significant reduction in ovarian hyperstimulation. And in that particular study, we started the metformin 2 months before the IVF cycle, and we actually stopped the metformin at the time of embryo transfer. What about the use of urinary or recombinant FSH for stimulation in polycystic ovaries? Does it make any difference in terms of egg quality? Well, I think any of you that have been to any of the ESHRE meetings will know that there's almost a routine session looking at meta-analyses of urinary versus recombinants to try and see which is the best across all patients. And I've been to presentations there where one meta-analysis has said that urinaries is better, followed 15 minutes later by a presentation that shows that recombinants is better. My own impression, I think this is borne out by the evidence, is that in terms of live birth rate, or indeed the risk of hyperstimulation, it probably doesn't make that much difference whether you use a urinary or a recombinant. And indeed, the Cochrane has looked at this specifically in patients with polycystic ovaries and has concluded in 2010 that there isn't any evidence to distinguish any benefit between recombinants and urinaries, specifically in polycystic ovarian patients. So I think use what you feel comfortable with. What about the addition of myo-inositol? Well, we've heard all about this morning, so I'll go through this slide very quickly. Again, the level of evidence here is quite good. There are prospective randomized controlled trials. In the best prospective randomized controlled trial, the dose was 2 milligrams twice a day. That's a 4 milligram dose with folic acid compared to folic acid alone, and it was given for 3 months prior to stimulation. And the treatment group had more leading large follicles, more eggs, more good quality embryos. But probably the most important thing to show that maybe this does have a biochemical reason as to why it works, there was a significant reduced number of immature eggs and degenerate eggs. So myo-inositol may prove useful in the treatment of these patients undergoing ovulation induction. I don't know what the situation is in India, but in London these days, patients seem to have more faith in their traditional Chinese doctors and their acupuncturists than they do in their gynecologists. And we have every second patient who's going down the road to see alternative medical practitioners, specifically for the use of Chinese herbs and for the use of acupuncture. And indeed, some of these are now being subject to randomized controlled trials. I put it in here simply because it's very popular with patients. and they all seem to be knocking on the door requesting it. Unfortunately, there is a Cochrane analysis on this looking at 4 prospective randomized controlled trials, and it shows no evidence for efficacy or safety for traditional Chinese medicine, specifically in polycystic ovarian syndrome. Okay, could in vitro maturation be the answer? Is it something that we're doing in our conventional protocols that may actually be producing these presumed abnormalities in the eggs? Certainly, it's probably going to be safer using IVM, and we'll be collecting the eggs sooner. Reducing gonadotropins will certainly reduce the ovarian hyperstimulation syndrome, probably make treatment a lot cheaper. And IVM's been around for several years now, and there are many enthusiasts or even evangelists around the world that believe that everybody should be having IVM. Successful oocyte recovery, maturation, fertilization, implantation, and live birth have all been reported. There have been some initial concerns about an increased risk for congenital abnormality, but I think most of the evidence about the babies born now is relatively reassuring. Interestingly, if you look at the Cochrane collaboration of systematic reviews on this from 2011, there are no trials available comparing IVM and conventional treatment. So it's very difficult to know. Within our own group in the Oxford unit, we've been doing IVM there now for about 4 years. We're the only unit in the United Kingdom that's actually licensed to do this. And the clinical pregnancy rate is 22%. Now, the difficulty is when patients say to you, well, if I just have conventional treatment, what are my options? And actually, in the similar patients, so in matched patients with polycystic ovaries having conventional treatment, we're able to achieve pregnancy rates of 45%. So it's very difficult for the patient because they're mainly tending to focus on the outcome, the chance of a live birth, as opposed to necessarily their risk of hyperstimulation. And indeed, I think if I was honest, I'd say we were disappointed with our results from IVM. And although we do offer it, we tend not to push it in the way that we probably did 4 or 5 years ago. And now we're reserving it potentially for the patients who have had very, very bad, potentially life-threatening hyperstimulation in the past. So I'm not convinced that IVM is the answer, certainly in terms of getting results or better egg quality. We've also heard this morning about GnRH agonist triggers in antagonist cycles. Again, this is an idea that's been pioneered by Humaden and the Danish teams. What's really interesting, and I think this is a lesson in terms of when we prepare talks and we look at evidence, we try and look at what's out there and what's been published. The overall sort of atmosphere within the field is, in fact, that GnRH antagonists followed by GnRH agonist triggers tend to be a really good, effective, and safe approach for these patients. But go and look at the Cochrane collaboration of 11 randomized controlled trials published in 2011. Yes, it does show lower hyperstimulation, lower ovarian hyperstimulation. It does show a higher miscarriage rate. It shows a lower live birth rate. And actually the conclusion is we should not be using antagonist cycles with GnRH agonist triggers. So who's right? And I think probably what this reflects is a time lag in evidence. And I think if you look at the original randomized controlled trials, specifically the work from Colobianakis and the Belgian group, the results were awful. But those trials were really well performed. So as a result, those trials are all within Cochrane. And I think they weight the evidence against the use of GnRH agonist triggers. My hope is that the work from Humaden, where he's really changed luteal phase support, as we heard earlier, actually will change this. And it wouldn't surprise me if there's a Cochrane review which actually changes its mind on this. And certainly, in our own unit, we've actually quite embraced this. And we're now moving all of our patients that we think are at risk for hyperstimulation, our polycystic ovarian patients, we've moved these over to antagonist protocols with GnRH agonist triggers, and we've changed our luteal phase support. And I put some data together before I came out of the first 53 cases, and we're seeing a 49% clinical pregnancy rate, and we've seen 1 case of ovarian hyperstimulation. So I think the use of GnRH agonist triggers in antagonist cycles for PCO patients is actually something that probably should be encouraged. And let's keep an eye on the Cochrane collaboration to see if they actually change their mind as more evidence comes in. And certainly we collaborate with an organization called Shady Grove in the United States, which is probably the largest egg donation service in the US, who have gone over to this approach completely for all their young egg donors. So these are women in their early 20s who are receiving very high doses of gonadotropin to get lots of eggs. And indeed, since they've been doing that, their stimulation rate has fallen to less than 1%. So, in conclusion, polycystic ovarian syndrome has been reported as being associated with very significant reductions in egg quality, and the reasons has been proposed because of abnormal circulating hormones in an abnormal follicle environment. But there is also an opposite body of evidence that actually shows normal fertilization rates and no impairment in oocyte or embryo quality. And so I think the original supposition that these patients automatically will have reductions in egg quality may not be true. And I think it's probably more subtle. And in my own view, I think it's actually the subgroup of patients with polycystic ovaries that have hyperinsulinemia and that are obese. These are the patients that seem to have the worst outcome and the worst quality eggs. And that's based on, again, Steve Franks working within our own group. Thank you very much.